Hi, my name's Mike Hayton. I'm a consultant orthopaedic hand surgeon and I want to talk to you briefly about Dupuytrens disease. Dupuytrens disease, or Dupuytrens contracture, is an extremely common condition affecting mainly Northern European people. The canvas, or I like to call it the canvas, on the front of the hand is a structure that allows the skin to be attached to the underlying deeper structures, and this enables the hand to be firm. This same canvas type material isn't on the back of the hand, which is mobile, and this rigidity and this firmness gives us the grip that we need to pick up objects. Dupuytrens disease is a condition whereby this fascia, or this canvas type material, thickens, contracts, and because the fascia goes down into the fingers, as it thickens and contracts and shortens, will gradually pull the fingers over. And here is a clinical photograph of a patient with very severe Dupuytrens, and you can see that the patient's fingers have clawed into the hands. The vast majority of patients do come to us a lot sooner than this when they have a very minor deformity with the finger at about 45 degrees. And we often ask the patients to put their hands onto the table, as I'm going to demonstrate to you now. Patients often come to us with an earlier disease, probably about 45 degrees. The thickened cord can be identified in the palm of the hand, and we often ask them to put their hand on the table. When a patient can't get their hand on the table, this is called the Houston's tabletop test, and it's perhaps a sign that the Dupuytrens disease is at a stage where it may require intervention, perhaps even surgically. Well, who gets Dupuytrens disease? I think the vast majority of patients, we now realise it's genetic and it's probably been passed down from either your father or your grandfather, but occasionally it can skip a generation. It's certainly more common in men than women by approximately 10 to 1. It's more common in patients of Northern European origin, and there's some debate about whether the Scandinavian gene is responsible for Dupuytrens disease. There are other associated factors of Dupuytrens disease: alcohol intake, epilepsy and its treatment can also be implicated in Dupuytrens. The vast majority of patients do have a genetic element to this, but some patients do not have any relatives that they know have got Dupuytrens disease. What symptoms do patients get with Dupuytrens disease? One of the early ones is the patient's finger starts to claw over. They'll catch their eye when they're washing in the morning. Another common problem that patients get with Dupuytrens disease is an inability to get their hands into their pockets. Some of my friends have got that problem, but don't seem to have Dupuytrens disease. Treatment. If a patient with Dupuytrens disease is getting significant functional problems, catching their finger in their eye, and inability to get their hands in their pockets, and perhaps even problems with shaking hands, they may wish to consider surgery. Surgery, in the vast majority of patients, is very successful, particularly when performed with early simple disease, the disease affecting the main knuckle joint. Once the middle knuckle joint becomes affected, surgery can have less predictable results. Although we can still often achieve a good result, we prefer it when it is only with the main knuckle joint. Surgery is performed either under general anaesthetic with you asleep or under regional anaesthetic with just your arm asleep. It's usually a day case procedure and takes anywhere between 20 minutes and an hour. Often a zigzag incision is applied to the front of the finger, the skin is elevated and moved out of the way, and the disease process can be identified. It's important at this point that we dissect out the disease, and here's an anatomical model showing the thickened grey Dupuytrens cords passing into the fingers. The yellow and the red nerve and blood vessel respectively need to be protected throughout this procedure, and this is one of the real risks associated with Dupuytrens disease surgery. Having removed all the Dupuytrens, we often release the tourniquet, which is a blood pressure cuff that allows us to operate in a bloodless field. We allow all the bleeding to stop and then stitch the skin with very tiny sutures. After the operation, the patient is given a temporary plaster of Paris that's just on the front of the hand, and then within 2 to 3 days after surgery, I refer all my patients to a hand therapist for splintage and urgent mobilisation. I think it's very important that the hand is moved quickly after the surgery. In rare circumstances, we put a skin graft, and in these cases, I usually let the hand settle down for 5 to 7 days for the skin graft to take. The stitches come out at about 10 to 14 days, and really we expect patients to be returned to pretty good function between 4 and 6 weeks after this surgery. There are risks associated with any surgery, and in particular with Dupuytren's disease. We do know that this disease comes back, and in the vast majority of patients it will come back if you live long enough. I quote patients, it may come back within 2 years or 30 years, but we can't predict that. And I'm sure it's how strong your genetic expression is as to whether the disease will return. Other risks are the small blood vessels and the nerves on either side of the finger can be damaged. Wound healing problems can also occur. It's important that the hand is used early after the surgery because we don't want the hand to get stiff or a painful pain syndrome to develop. And these can be guided with your hand therapy that we often recommend after such surgery.